Echo. Looking forward to our presentations today and moving through this. And I am, happy to say that we have done 6 echoes with IBH in primary care with our QI echo. So happy to say that we've done that, and kind of sad to say that this is our last one today. So just gonna call that out. So thank you all for your participation and engagement. It's been fabulous. Our data usage notification is here again because the tele-echo program is very, wants to know who's participating in kind of our topics. So thank you again for the data notification piece and sharing. Some things about the Zoom as usual. If you have trouble with the Zoom, let us know and we will give you a hand with that. We're all pretty much getting to be pros at this point, however, so which is really good. So today what I wanted to do is, these are our ECHO participant organizations. What I'd like to do is I'll call out the organization's name, and if you guys can just unmute yourselves and say hello or good morning, that would be fabulous. With our core hub subject matter experts, Allina Health.
Morning.
Hey, good morning. And Children's Minnesota. Okay. Hennepin Healthcare. Okay. M Health Fairview. Okay. North Memorial. All right. Sanford Health. I know I see Jeff.
Yeah, good morning, everybody. It's good to see you.
Awesome. Thank you. Thank you. And then for our Spoker learner organizations, Community Health Services, Inc. Today, Karen is feeling ill and is not able to join us, and she's also our case presenter today. So I will have us weigh in a little bit about what we're going to do with that after our didactic. Tyra Family Clinics.
Good morning.
Hi, Allie. And Fairview Masaba Clinic in Hibbing.
Good morning.
Hey,
Good morning.
Lake Superior Community Health Services. Okay. Open Door Health Center.
Yes, hi, I'm here, and I believe my intern Chelsea is also on
Oh,
Yeah,
welcome.
I'm here too.
Welcome.
the line.
Thank you.
Lisa's here also.
Okay,
Oh.
great. Hi, Lisa.
Thank you.
Morning.
Good morning. Ortonville Area Health Services.
This
Good
is
morning.
Twyla.
Hi, Twyla.
This is
Hi,
Liz.
Liz. Good
This is
morning.
Sarah.
Hi, Sarah. Awesome. Okay, anyone else out there that needs to say good morning? Okay, awesome. Well, thank you, everybody. Good morning. So this morning we are very lucky and happy to have Allina Health is going to present, and Mirza is going to go ahead and present on population-based care, suicide prevention. So Mirza, do you want to go ahead and introduce yourself, and we'll get started with the didactic piece?
Yes, I'm an integrated psychiatrist at Allina Health, so I'm essentially a consultative model. I also chair our mental health program committee, which is responsible for sort of quality process improvements, improving standard of care in mental health. And we have Kathy Charlo as well, Dr. Kathy Charlo.
Okay.
Kathy?
Sure. My name is Kathy Charlo. I'm a child and adolescent psychologist at our Allina Health Bandana Square Clinic in our pediatric department, and I also am a system manager of integrated care, and in particular also run our mental health consultant program, which serves immediate access to mental health care in primary care clinics, a program that is expanding significantly in 2020 and 2021.
Awesome.
Today we're going to speak towards the focus principle of population-based care, so essentially population health management. We are talking about pilots, so the concept doesn't completely apply, but that is our target concept, target principle. We have a number of processes or principles that we are also targeting. So essentially evidence-based care, patient-centric care, conduct efficient team care would also fall under our topic today. What we want to do today is to convey our implementation process for suicide prevention quality improvement. So essentially talk about our suicide prevention program, specifically our program in primary care, and also getting an understanding of the level of suicide risk in 2 clinic populations where we piloted our program. So again, we're going to talk about suicide prevention in primary care under IBH. So essentially, we're piloting, we are pursuing a suicide prevention program currently in our emergency rooms and primary care. At some point, we will in mental health and eventually other areas, but these are our focus areas. We have completed 2 primary care pilot sites, so they have already completed. So those 2 clinics are Faribault and Shakopee, and we use in these pilots and in our eventual rollout, we'll use a cascade screening process. What that means is that patients, we have the standard process with the PHQ-2 and the PHQ-9. If a patient doesn't have depression, they might fall into the PHQ-2 annually, I believe. So eventually, so if the PHQ-2 is positive or patients get the PHQ-9, it goes, well, to the PHQ-9. And if you look here, it's this last question that triggers the cascade screening to our suicide screening tool. So the thoughts of death or suicidal thoughts on the PHQ-9. So if that's positive, then patients would receive the Columbia Suicide Severity Rating Scale. And this is the specific version of the Columbia Suicide Severity Rating Scale we're using. It's the recent self-report. So there are a lot of different versions. They're largely very similar with some slight differences based on settings. So for example, in our emergency rooms, we're using a triage version, which has sort of like this, the questions are basically the same. There might be a couple minor differences, but they're process is a little different, and there's sort of this highlighting or coloring. It's a little different. This version of the Columbia is specifically given to the patient to fill out if they're screened positive via the PHQ-9. So again, it's any thoughts of death or suicidal thoughts. It doesn't matter as long as it's positive. They get this. The goal is to get this screening tool. And so, are all of you familiar with the Columbia?
Go ahead and unmute yourselves and let us know.
Mirza, this is Jeff Leichter from Sanford. We're doing the exact same thing with the cascade from the PHQ-9 to the Columbia as well in our primary care clinics.
Good to know.
Okay. Anyone else?
Ortonville is doing the same as Sanford.
Okay.
And this is coming from the Lighthouse Project. It's very easy if your organizations don't have this in place or would like to pursue the Columbia. It's very easy if you go to the Lighthouse Project website. It's free. You do need to request authorization from them, but it's a pretty simple process. And so essentially, just to review this very quickly, so the first question is passive. So the first 2 questions are clarifying passive thoughts of death versus suicidal ideations. And our data did show that when we were building the framework or the clinical pathway for the suicide prevention program, and prior to implementation, there's a lot of anxiety about implementing this tool. And some of the data from, for example, Henry Ford Health System, which was one of the first healthcare organizations, 19, 20 years ago to start a suicide prevention program, was showing that in primary care, it's actually pretty uncommon that one would get a patient any one primary care provider or team would get a high-risk patient that needed to go to the hospital. And so we tried, even though we didn't have our own data at that point, it built a lot of anxiety, but we used the Henry Ford Health system data to help, push our initiative forward. And it turns out some of the data, early data we've had reflects it, and I think we can relax somewhat about the need or how much more energy is required or time for implementing this kind of tool in a broad number of practices. So again, it's clarifying. It's not just saying the last question of PHQ-9 is pretty vague, thoughts of death or suicidal thoughts. Most patients are going to have passive thoughts of death and not suicidal thoughts. But this is really going to clarify this. And if they're not having suicidal thoughts in the last month, we skip these 3 questions. So this is another way, we're going to talk about a little bit of change management in a bit. But essentially, when we were talking to leaders concerned about the impact of implementing this tool, this is a key point. Most patients are going to skip, they're going to have a 3-item questionnaire, not a 6. Most patients are just going to completely skip 3 to 5. And the data shows that as well. And so if someone is having suicidal thoughts in the last month, it clarifies intent, plans, and so forth. The last question is, well, it says it's really asking in the last 3 months if there were steps taken towards suicide, if there was an attempt. And so it's to get a little bit more data over a little broader period of time on understanding any suicide-related behaviors.
Okay.
Next slide, please. And so essentially what happens is the patient is roomed by nursing staff. They fill out the PHQ-9. If it's positive, they are then provided the Columbia. I believe, if I'm not mistaken, I believe the latest process is that the Columbia is on the backside of the PHQ-9. I don't exactly remember, but I believe that's what was at least talked about. So then if the last question is positive, then the patient fills out the Columbia. So that's provided to the patient by the nursing staff. The results of the PHQ-9 and the Columbia are input to the flow sheet under our medical record. The flow sheet is just saying what the results are, basically. We did develop risk stratification guidelines, which are here. I think the ones on the Columbia we felt were a little too stringent because I mean, in general, there's a lack of mental health resources, especially psychiatry. So when you have a low risk stratification guideline suggesting psychiatry, that may not work out so well in terms of resource management. But essentially, we did sort of ease up on the restriction, on the risk stratification guidelines. And we made a point to say that this isn't meant to replace clinical judgment. This is a key point. People should not be making decisions about whether they should send a patient to the hospital based on these risk stratification guidelines. I have, of the patients, for example, in my own integrated practice, of the patients that under the Columbia that do get ranked high risk, very few of them, actually hardly any, go to the emergency room. And a lot of these patients are actually workable. I wouldn't necessarily tell that to a primary care provider because they have a different training and skill set. But we really try to suggest, with organizations considering implementing this, that this is a guideline. It is not meant to replace clinical decision making. Next slide, please. Oh, thank you. So essentially, just want to talk about some of the issues we've had. I will say that our pilots were largely successful, but there are some change management issues, which we've talked about briefly. We had complaints from providers about the time involved. There was a separate complaint that the provider felt that they already knew what to ask the patient, and they didn't see this screening tool as necessary. Difficulty. So when I talk about this, when we talk about these challenges with team alignment with the risk stratification guidelines, we have a committee that's sort of was overseeing these pilots. And so in creating something new, we had some differences in how we approached it, which I do feel were resolved. But there are some challenges in getting our group to agree and come together. And not in terms of there weren't like arguments, or it wasn't to that extent, but ultimately that was resolved. You know, this line says addressed by refusing to accept no. I wouldn't take a no answer. You know, so if my quality improvement partner, was hesitant about a certain, can we do this? I'm not taking a no answer. I think a little bit it helped, and I think others took that same position. So there was a point in our group when we were the point came up: should we really do this? What about our resources? And some change anxieties essentially. And nope. We're not taking no. We're pushing forward in a kind way. It wasn't that brunt. So I mean, motivation is important. You need to get people motivated using stories. So we had a couple of success stories. One in particular, a patient that I think was planning on taking their life by train on train tracks, and they were screened using the Columbia and saw the mental health consultant in the clinic and received treatment. And the feedback from the mental health consultant who saw the patient was that this could have saved that patient's life. I can tell you, I have my own patients that through suicide screening that even if they denied suicidal thoughts, but there was some concern about certain things said, we did talk about suicidal thoughts. We've had training, and later, a few months after I saw the patient I saw, they were telling me like, I was actually going to take my life when I talked to you, but when we talked about suicide, I thought about things and I started to work on things instead. And so I mean, I think screening helps. It's not the entire solution, but it certainly helps. And it certainly brings to light what of our patients might need further services. We've also had to make changes to simplify things. So there's sort of the quality improvement process. Next slide, please. Oh, thank you. This is some data just from the 2 clinics. And so you can see in this first one how many patients that took the PHQ-9 had a positive last question about passive thoughts of death or suicidal thoughts. And then of those patients, how many received the Columbia? And then how many received a follow-up appointment after that? So 60 to 70% roughly of patients were getting screened with a Columbia that were positive on the last question of the PHQ-9. I should talk about universal screening a little bit. I'll come back to that. And so this is over like a week of January 10. And so we were wrapping up at that point. We wrapped up the pilot or around that time, and so we were finishing the pilot, or had already finished the pilot. So these numbers are a lot lower. So essentially, system-wide, 400 to 500 patients answer the last question of the PHQ-9 each week. The last question of the PHQ-9 as positive. And that's separate from this data. This is pilot data. This information is broader. So 400 to 500 patients they have passive thoughts of death or suicidal thoughts, and we catch those patients about 400 to 500 times each week. And then there were more follow-up appointments at our pilots than there were with clinics that didn't have the Columbia Cascade screening process. There was additional time for staff in the rooming process. There is an additional questionnaire. There's additional input. We did have limited physician feedback, and we had certain complaints. They weren't enough to say we need to rethink our whole entire process, but so we had thought about having a survey. And Kathy will speak to this, but essentially the feedback from our mental health consultants was that this has not resulted in a large increase in patients. I should have clarified a little bit what mental health consultants are, and we'll do so in a little bit, but essentially they're an immediate access mental health care provider. But schedules were not overloaded from our pilot, which was good news in my opinion. And I meant to speak to universal screening, and then we'll go to Kathy real quick. So in universal screening, what we call cascade screening is it starts with a depression questionnaire, and if that's positive, then goes to the Columbia, the suicide questionnaire. In universal screening, every patient at some level, at an unspecified interval, receives this screening on a regular basis, maybe annually or so. But anyhow, that's the difference. You do catch more patients by some of the studies by doing universal, but it's easier to implement cascade screening first. Kathy?
So when we elected to try the pilot at 2 Allina Health primary care clinics, we were intentional about choosing primary care clinics that both had mental health consultants who were very experienced in our mental health consultant program and had worked in the field of, they're all licensed independent clinical social workers as mental health consultants at Allina Health, and they were very experienced in their field. They were basically the frontline care immediately available when patients screened positive on the Columbia. And what we did is we took their schedules and we made sure that in the AM morning section of their schedule and in the afternoon section of their schedule, that we always had suicide prevention pilot slots reserved so that no patient could go unseen. What we did find, which was interesting, Mirza mentioned that we didn't see our mental health consultant capacity strained as a result of the Columbia. What we did see is that primary care physicians became very adept at locating the mental health consultant in the building with an immediacy to place the patient toward the front and center of care in the moment if there was in the red high enough risk that there was concern. We also got a lot of feedback that primary care physicians, when they had a long-term history of treating patients, that they were able to come to conclusions about what the patient needed next. So we didn't see a major concern in terms of being able to hold capacity on this. And then Mirza has bulleted one of the challenges that not all sites have mental health consultants at Allina Health. That is definitely true. It was mentioned early in the morning before you were on, Mirza, that there might be some extra time to talk about the mental health consultant program later this morning because the person who was going to do a case consultation presentation today is ill. But essentially, we don't have mental health consultants at every site at Allina Health. We have a metric to determine where we strategically place our mental health consultants. And right now, only clinics that have 30,000 arrived visits per year become eligible for our assessment process. And by the summer, we will be up and running at about 20, I think it is exactly 20 Allina Health clinics, including 2 of our hospital-based clinics. And that is, of course, only a percentage of Allina's overall clinics, and the goal is to eventually have a mental health consultant at every clinic. We're just obviously now in a very unprecedented circumstance of going to an online service for all patients, but we are completely up and running virtually, and we are also completing the PHQ-9 as well as the Columbia virtually.
Thank you.
Wanted to take a moment and talk about some points about motivation motivating organizational change. And so some of the challenges involved are, again, suicide prevention involves different or additional screening tools. Changes occur from staff through administration, so it's not a simple change. Training is involved. There's an educational component. There's a fear of change. There's also, more in primary care providers, a fear of being overwhelmed with discovering suicidal patients. Well, now we know, but then what do we do? And so those were some of the challenges and fears we came across and had to address by implementing training, being frank with other leaders about some of the challenges with this process, because it's not an easy one. And addressing fears and creating pilots and not rushing implementation is, some of us were quite impulsive to start our pilots or start process, but we took a incremental approach, including pilots, and I think that's been a very helpful process. So again, some other points, you want to focus on the goal. So I remember sitting at a meeting with primary care leaders, and I heard them say, well, I don't want our primary care providers to do CBT, cognitive behavioral therapy. And in my head, I'm like, it's not CBT. But your verbal response is you focus on what the goal is, saving lives. This isn't CBT, and you wouldn't necessarily share what you have in your head with the group, but and we spent a lot of time developing a clear suicide prevention clinical pathway. So what do you do from screening to intervention to follow-up or follow-up intervention? And so we had this beautiful clinical pathway, and I think having a clear plan in terms of how to manage a patient, at least a future plan or a framework, was helpful. Frankly, an elevator speech about suicide, you will hear a lot of, especially when it comes to big changes, you will have a lot of criticisms about it. And to be fair, they were all basically constructive. None of them were they were constructive criticisms. So you respond kindly to those. Some of those criticisms, like the idea that primary care providers are going to be doing cognitive behavioral therapy for their patients, that's just not true. But you respond kindly to it, and just sort of roll with the punches or the resistance, if you will. We've had obviously this is, I can't, this has been the pandemic has been a tremendous impact. We are putting things on hold. So it's on pause. Our development in primary care is currently on pause because we're doing this incredible reorganization of our clinics to manage the patients that are getting infected, the future patients that we're expecting to get infected. So we're putting this on hold, and the idea is that suicidal patients maybe are at home. If they're not living alone, they're spending more time with people. If we do see that there's a concern about suicide risk with the pandemic, mental health, anxiety, depression rates are higher. People are struggling. But if I see anything concerning about suicide risk with the pandemic, I'll bring it up. We'll bring it up. And see what we can do about that risk in terms of our initiative. Future goals, expansion of our primary care program. So before the pandemic hit and we had to restructure basically everything, essentially we sought to expand to all of our clinics. We didn't formally develop an implementation plan, but we did develop some preliminary expansion plans. So next step at post-successful primary care pilots, 2 pilots. Then we expand to our clinics, primary care clinics that do have mental health consultants, so whatever the 9 or so. And we also developed so here's another important piece. So when we started this initiative, we developed one Columbia to use across all settings. The problem was that our emergency rooms developed that Columbia suicide screening tool in our electronic medical record. So I mentioned there were a couple of differences between the version I showed you here and what is being done in our emergency rooms. And I can tell you when we did the pilots, having an emergency room driven Columbia used in our outpatient settings, even though we talked, even though the idea was like, we were told it would work, but and it does work, but you have some challenges. So the wording's different when a nurse is rooming the patient and trying to apply the self-report Columbia to this emergency room and actually hospital based Columbia. It doesn't translate the questions, the answers aren't quite linear. In the emergency rooms and hospitals, they're asked to the patient by the team. Whereas in outpatient, it's a self-report version, and it didn't quite effectively translate. It works, but not efficiently. So we did actually develop one specific to the self-report version, as well as a last contact. So there's a version of the Columbia where you can ask the patient those questions, but since the last visit or last contact. So that's the other piece. You don't need to ask patients every, if they have an appointment every 2 weeks, there's some repetition. And there's a version of the Columbia that's all the questions are geared instead of the last month since the last contact. So we have, those are workflows in place now. Expansion into mental health settings, psychiatry, ambulatory settings, specifically inpatient units. There's a redesign project going on. Expansion into other areas of healthcare, and the possibility of telehealth services, which with how quickly things have changed, evolved into virtual care. This has been a positive of the pandemic for suicide prevention, is that we've had a rapid expansion of virtual care. And so that was something we could use as a resource for our suicide prevention initiative, now is in play, well ahead of time.
All right. Well, thank you so much, Mirza, for sharing. I think what I'd like to do is ask the group questions, comments. What I'd like to do is shape this as they've been shaping some of the COVID echoes that I've been in. So what we'll do here is we've heard the presentation from Mirza and from Kathy, and what I'd like you to do now is comments, any questions for Mirza, and let's stay focused to this topic, because I heard screening is important. The cascading piece is really, it sounds like it's in use in other organizations as well. What are those really salient points that would help our organizations that maybe aren't in this place, help them understand, how do I get started, or what are the key pieces I need to consider? I'm going to open it up. Questions, thoughts for Mirza, Catherine?
Hi, this is Jeff from Stanford. So Mirza and Kathy, thank you for that presentation. It's very validating to see that from our friends at Allina, because if you had slapped a Stanford label on this PowerPoint slide deck, it would have been our slide deck as well. So that made me feel really good. We've been doing universal behavioral health screening in primary care since about 2012, but only relatively recently did we add on the Columbia screener for that process, probably in the last year or two. And what really helped us pivot to including that, particularly in light of Mirza's comment about some of the resistance and screening fatigue that our providers have, was that we lifted up a 2013 study, and Jeyn, I'll send this to you so you can distribute it to the team. But there was a study in 2013 that looked at over 200,000 administrations of the PHQ-9 in roughly 85,000 patients. And it looked at what was the predictive validity of question number 9 as far as subsequent suicide attempts or completed suicide deaths. And what the study found was that in the short term, meaning within 30 days, there was no answer on question number 9 that predicted a suicide attempt or death better than the other. So in other words, if somebody said, I'm having these thoughts nearly every day, they actually had no different risk than somebody that said not at all. And that was very eye-opening for us. And what it really kind of demonstrated to us was we can't trust question number 9 as a standalone screening question for suicide. We needed to add the Columbia as well. So when we were able to lift that up, and physician leaders, they like listening to psychologists, but what they like even more is when data shows that something is empirically derived and not just some psychologist's opinion who walks into primary care. So once we began to lift that up and show that study, people began to say, yeah, we really do need to use the Columbia in addition to the PHQ-9. And I still have that, sitting in my files. And when somebody new comes along and says, well, why are we doing the Columbia? I whoop out that article every time. And because of the robust nature of the study, with almost 100,000 people, it's pretty convincing. So thank you for that presentation. And Jeyn, I'm going to send that study to you right now.
Thank you. Thank you. That's great. We'll include that. Other comments or thoughts?
I just wanted to say a follow-up quickly, which is that I think one of the things that you learn with integrated mental health care in primary care is that our primary care teams are the front lines of really everything in clinic. And one of the things I think that was most humbling and also brought tremendous awareness to me about the ask of anything that you add is that you definitely find physicians very motivated by other physicians who have had experiences of loss of patients to suicide. That was extremely motivating. But you also realize that in the context of asking your physician teams to add a screener, that is in the context of so many other heavy lifts that they're asked to attend to daily. And I think one of the things that really struck a chord with me was I was going to a meeting about this at a clinic, and the people that I was meeting with, the team of physicians that I was meeting with, they were literally just coming from an hour-and-a-half training on post-surgical wound care for cardiac patients. And so to completely shift gears and realize how much they're really taking in on a daily basis, I think gave us a lot of point of view of that it does take time to expand these kinds of care programs, even though everybody agrees that they're extremely important.
Thank you. Other thoughts, comments, questions?
I should mention the tool, what happens, what is our intervention tool for a suicidal patient? It is the safety planning intervention. So patients that are see the mental health consultant may get a safety plan, a Stanley Brown safety plan.
And that is completed by a mental health consultant or a psychology provider at this point in time at Allina. And I think one of the real tests of change with utilizing the Columbia is going to see how this measure can roll out at sites that do not have mental health care immediately on site. And I actually think with the advent of all the telehealth services in the last couple of weeks, we are going to have greater success widely rolling this out, because we do even have primary care clinics still that don't have any mental health providers.
Mm-hmm. And I think that's a key point, Kathy, that you bring up is, what if you don't have any mental health providers on site? Are there words of wisdom that the experts on our call today can offer?
I think that would be great, because one of the things that primary care first says to us is, okay, so we get this screening, we see that it's in the red, what next?
I mean,
Hi,
it's
this
it's a
is
significant challenge. There's not an easy answer. I mean, having virtual services is I think key. I agree. It's not there's no easy solution though if there's not access to telehealth services. Um, I think there are various trainings for suicide prevention work, QPR and others that might be more applicable to primary care if that was um, a situation such that there was any lack of resources and um, it was difficult.
this is Sarah from Ortonville. Can you hear me?
Yes, Sarah, we can hear you.
All right. Just wondering, what is a mental health consultant and what type of degree do they have?
A mental health consultant is a licensed independent clinical social worker. So they have a master's in social work, and the licensed independent clinical social workers who are mental health consultants at Allina Health have experience both in diagnostic assessment as well as short-term therapy interventions. Many of them have been hired from emergency department assessment and referral departments because the volume and acuity of patients in an emergency department, although often higher than what you would see in primary care in terms of acuity, the type of skill base is very important because you're able to shift attention from one high intensity situation to the next. And we've deliberately decided in our program that we are not going to veer from the licensed independent clinical social work decision on hire, because we feel that the combination of assessment and referral skills, the kind of administrative thinking skills of a social worker as well as their clinical skills match really, really well, and complement the more specialty psychology and psychiatry that we have and complement primary care. And I am a PhD level child psychologist, but I was actually the first clinician involved in starting the program at Allina Health way back about 6 years ago. And I think one of the reasons that there is value to having a clinical leader, that I am a very integrated clinical leader and like to do a lot of the social work functions, but also I think the clinical assistance that I can give with child and adolescent cases as well as adult cases has been really, really helpful just in expanding the clinical confidence of our team.
Okay. What are others doing out there? Because I know, Jeff, you guys have a program. I know Sarah, Liz, and Twyla, you also do. And I know that your settings are different for those organizations as well.
Well, at Sanford, and I think we've talked about this before, so I'll keep it brief, but we launched integrated behavioral health in 2012. We were very fortunate to be the recipients of a CMS grant for 3 years, and that allowed us to really go from kind of co-located care to integrated care. So Sanford has about 300 primary care clinics, and we've got what we call integrated health therapists, or IHTs, which is exactly the same thing that Kathy was talking about, but we call them IHTs. We have them in about 50 of those primary care clinics right now. And we're also doing tele-integrated behavioral health to probably roughly 15 or so more clinics in rural North Dakota, rural Minnesota, and rural South Dakota. So we've got about 65 of our 300 clinics covered with a master's prepared clinical social worker, or in some cases, a licensed professional clinical counselor. And we do try to follow that PCBH model so that they're not seeing those patients in extensive psychotherapy, but assessment, triage, diagnosis, and short-term care, like 6 visits or less. It is a challenge, as Mirza was saying, whether they have suicidal ideation or not. But in those really, really rural clinics where we don't have a mental health presence, we are asking those providers to still do the screening. But as Mirza and Kathy said, the pushback we get is, okay, we'll do the screening, but now we're in a town of 900 people, and what are we supposed to do? There's no psychiatric unit within 100 miles of here. So we are still struggling with that. We have tried to repurpose some of our RNs to be kind of stand-in behavioral health triage professionals. But I'm not going to say that we've solved those problems. And Sanford's footprint is just so vast into very rural areas that those are really bugaboos for us.
Thank you.
One of the things I just wanted to tag on when Sarah asked the question, we see all comers of all ages. So it is any children, adolescents, and adults. And we have worked out a system so that a very vast number of our services are billable. And so that's been helpful in the sustainability of the program. Not everything is billable, but we've worked out a treatment plan program where we are able to capture some of this. And so that's been helpful in terms of expansion in this era of healthcare.
Thank you. We have about 10 minutes left today. So other questions, curious thoughts that are out there, please go ahead and put them out while we've got everyone together.
I was curious to know if the Sanford Health model is also a billable model for some of the services.
Well, I mean, that's an everyday conversation, Kathy, that we have, but there is an RVU expectation for our integrated health therapists. And we've spent quite a bit of time over the last several years with our enterprise coding specialists, trying to make sure that what our IHTs do is billable. Now, we know that under 16 minutes makes it impossible to use one of the standard CPT codes. So we kind of just absorb those as being a way to enhance primary care, and we're making the assumption that even if they're not billable, that those people are being potentially diverted away from the emergency department, or at the very least, they're not busting up the schedule of primary care because it allows that physician or APP to move on to another patient while the integrated therapist does whatever is necessary with that patient. So in the old model, that physician might have been bogged down in a 30 to 40 minute appointment, and that may have made it difficult to take care of the other primary care patients. But to answer your question, there is an expectation, and I would say that we're meeting that expectation most of our clinics, some not, and it's kind of an everyday, every hour challenge for us.
Thank you. Yeah, we call it emergency department diverts also in our program, and we've been very successful with several hundred a year, which I think is great patient care, being able to take care of patients in clinic rather than in an emergency department. And I'm sure for a rural area, that is just extremely important to be able to have that access.
Mm-hmm. Thank you. Any other thoughts? I'll leave it open while I kind of page through the slides here a bit to the end.
This is Twyla in Ortonville, and we're more of a rural setting. I am a psychiatric mental health nurse practitioner, and I'm the mental health provider that's embedded within our clinic. And what we have with our primary care is what I'm going to call some curbside consults, where the primary care provider might catch me in the hall and ask additional questions and just like ideas or placements. Should this person go to the ER? What are our options? And a lot of times I'll give advice at that point. Periodically might pop in the room with the provider to kind of help navigate some of that. And then the individual usually will have follow-up care either with me or with another local provider within our community. so they're not going without resources or help. Because we have lack of resources in our ER. We do have some telehealth in a mobile crisis response team that we can turn to, but it's not always an immediate, we're right there type resource.
Thank you.
I'm just going to tag on to that a little bit. We've done a lot of work here, as Jen knows, with our mental health, and having Twyla on board as I'm a clinic nurse, and asking those questions and getting that yes answer is so uncomfortable when you don't have those resources available. So just having her there takes a lot of that stress off for nurses.
Awesome. Thank you, Sarah. Okay. Other thoughts as we are getting ready to wrap up here today? I think in a general high level sense, Gretchen, I'm going to take a shot at the high level, what I think we heard today. Really that the resource of the Columbia, the Lighthouse Project would be a resource we will peg for you folks, as well as hearing about that the PHQ-9, the number 9 question alone, there's more that should be addressed, which gets us into adding the Columbia screening, and the article that Jeff has sent, I will pass on to you folks. So I think the consideration of screening, and having a process within your organizations will serve your patients and your clinicians the best. I think that's my overall kind of ball of wax. Anything to add to that, Mirza, Catherine, Gretchen?
One of the other things that I heard was just that it seems like several of the larger systems are kind of falling into the same process. And so I know we're out of time, but I thought it would have been interesting to hear if any of the smaller systems or just any of the other systems on the call were also doing the same process, or if they had a significantly different process that was working for them or that wasn't working for them. But anyway,
Well,
as a summary, it sounds like so far everybody that's talked, it sounds like is going in a similar direction.
and we do have 4 minutes left, so anyone out there that can surface anything about the question Gretchen put forward for us? Okay, thank you. So thank you all so much for your time, engagement, and just really participating with our ECHO. You will get an evaluation through SurveyMonkey as usual. Please go ahead and fill that out for us. And we'll send out a kind of a final summary kind of overview for you folks within the next few weeks. Please reach back and let us know if there's anything that we can help with. I'll also send a link out to a mental health kind of group that we have started here on Tuesdays at ICSI, that for mental health folks. So what I'll do is I'll send that out to you as well. But thank you all very, very much, and have a great day and stay well. Thank you.
Thank you.
Bye. Thank you.